Good morning, Cesar. Good evening for people in India. On behalf of Sri Devaraja's Academy of Higher Education and Research, University Center for Health Professions Education, I extend a warm welcome to all of you. UCHP, as we are called, has been organizing webinars with the objective of disseminating principles and practices that facilitate competency-based education. The competency encompasses, as we know, a behavioral set of skills, attitudes, and knowledge. And skill is that ability that one needs to acquire to be competent. As we go global in the practice of educational principles, it is pertinent that we have experts whose experience will provide insights for educators all over the world to institutionalize and raise the benchmark of medical education. So we have an expert in this regard, Dr. Cesar. I'm so happy he is with us. And I request our Director of Academics, Dr. Sarala, to introduce the guest speaker to the audience. Over to you, Dr. Sarala.
A very good morning to Dr. Cesar and good evening to all the participants here. So it's my pleasure to introduce Dr. Cesar Alberto. He's originally from Monterrey, Mexico. He's a graduate of Tecnológico de Monterrey School of Medicine. He has specialized in pediatrics in multicentric program of Ministry of Health and Tecnológico de Monterrey, where he has served as a chief resident. He has international clinical experience in settings such as Baylor College of Medicine, Houston, Texas, and Hospital for Sick Children in Toronto, Canada. He works as an editorial advisor regarding issues related to health within the newspaper El Norte. Likewise, he is TEDx speaker with his talk, Global Health Personal Attitude. He has presented conferences and research projects in both national and international settings, like the Association of Medical Education in Europe and Reimagine Education, among the others. He is a fellow and professor of FEMA, based in Philadelphia, United States. Likewise, he is a fellow of International Association of Medical Education. He has a postgraduate degree in medical education with an emphasis on accreditation and evaluation from Kiel University in United Kingdom. He is a member of National Board of Medical Examiners IFO Test Design Committee. He has been awarded the Teaching Excellence Award by the Universitas 21 International Consortium in the area of health sciences. He is the General Director of the company EduMed Experts, dedicated to providing consultation and technological solutions in evaluation and certification within the field of health. Currently, he serves as National Director of Academic Societies of the TechSult School of Medicine and Health Sciences of Tecnológico de Monterrey. He is a professor of pediatrics and global health in undergraduate and graduate areas. Likewise, he has his private practice in pediatrics at Zambrano Helion Texel Hospital. This is very much in brief about Dr. Cesar. Over to you, Cesar.
Thank you very much for inviting me to speak to your colleagues and medical educators. Today, I would like to share with you some. I had a long time thinking about why would I want to share with you. You know, if I would share with you, assessment methods or rubrics or like. But I wanted to speak to you as a fellow clinician educator, as a fellow clinical faculty, and like what has worked for me, what has worked for like different clinical educators groups regarding clinical skills assessment. So we're going to talk a little bit about good practices, tips, and other resources that you might find interesting. I'm going to share my screen. So I'm a professor, like you just heard, from Tecnológico de Monterrey. We are the the #1 ranked private university in the country and in the top 15 in Latin America. We are based in Monterrey, Mexico, which is right there in the northern part of Mexico, very, very close to the United States, 2-hour drive. So you can try to put us on the map. There's where we are. And I wanted to start with a quote that I find useful sometimes, that it says, clinical skills assessment by observing a student's performance is going to allow us to assess competencies that are impossible to assess in a written exam. Responsibility, integrity, compassion, maturity, professionalism, the application of clinical knowledge, how to solve a health problem. All of these are elements that are going to be that we are able to assess in different ways when we observe our students or our trainees interact directly with patients. Another quote, and this is by Paul Hemmer. Another quote by William McGahey is as clinical faculty, us who are every day at the bedside with the patient, with our students, with our residents, we have a moral and professional obligation to ensure that any student that is going to leave our program has a minimum level of clinical skill. And on top of that, is able to treat patients safely, effectively, in a compassionate manner. Sometimes we, as clinical educators, we say, the responsibilities, is the dean's responsibility or the medical school responsibility, but we, as faculty and professors and that are in charge of training students, their responsibility is also ours. So clinical skills assessment and clinical teaching it's a very important part of our students' formation, is where they get to integrate all of their knowledge. Recently, we had a visit of Kees van der Vleuten, which some of you might know, which is he's based in Maastricht, and I wrote down some of the quotes that he said that I liked. For example, clinical skills must be observed and evaluated over time, longitudinally. Okay, sometimes we want, to do an OSCE or maybe observe a student at the bedside and try to make objective assessment of that specific photograph of that student in time. And even though that is valuable, we need to always look at assessment in a programmatic fashion. Like, how can I observe this student perform these clinical skills, not once, not twice, but several times in several different scenarios across the student's training. Also, a single assessment is no assessment, or a single evaluation is not evaluation. In Spanish, we use the same word for assessment and evaluation. We don't have two different words, so that's why I translated like this. But like just one assessment of one moment is not enough, because it's very common that we hear among colleagues, clinical skills assessment is very subjective, for example. Like it depends on the eye of the beholder. Well, yes, but if a lot of us make a lot of observations and assessments of the same student, then many subjective judgments are going to make a fairly robust and objective judgment. Okay, so that's why it's so important to try to observe and to assess a student's or a trainee's performance and skills across time in different ways with different methods, so we can build an objective judgment of that student's performance. Also, we're going to talk a little bit about that. There should be no assessment without feedback, because assessment in clinical skills without feedback it can be very sterile, very lack of meaning. So feedback is always very important. We're going to talk a little bit more about that later during the talk. In this phrase that we hear a lot, this is assessment drives learning. So imagine you have a luxury sports car, a Lamborghini or a Ferrari sitting right there in your office, in your operation room, doing rounds. But without proper assessment, or without proper motivation for that student to improve, it's like you have that car without a motor, without an engine. It's just, just a very pretty, shell, but without something that actually makes the car move. So assessment is that engine, is that motor of that car. Clinical teaching can have several strengths. The first one in clinical skills assessment, the first one is that we can, as often as possible, that we can focus it on real problems. Okay, now when they're in the clinical years, they're not in the classroom anymore. We're not dealing with pieces of paper. We're not dealing with physiopathology. We're dealing with real patients and real patients' problems. So that can mean a lot to a student if we try to focus the attention of how are we going to solve the problem for this patient. The focus shouldn't be like, how am I going to pass this test? How am I going to get certain mark? If we try to shift it towards how are we going to solve this real problem, that can be have more impact and be more meaningful to a student, and it can help the student learn more. And finally, after all these years where the students have acquired knowledge about history taking, physical examination, clinical judgment, physiopathology, professionalism, everything is going to get integrated at last when they are interacting with patients, either real patients or simulated patients or standardized patients. Everything is going to finally click and make sense when they are actually solving a real problem. So that's one of the big strengths of clinical skills teaching and assessment, is that it's finally going to make sense for the student. Also, students are active participants. They are like, finally, hopefully they're going to pass from they're going to shift from a passive state, a stagnant state of just learning in the classroom, to actually be members of the health team, which is what we want. This is in these years when they're doing clinical teaching and clinical assessment, is where their professional behaviors and their attitudes are going to be modeled. Is when they're going to learn how to become doctors finally. But there's lots of challenges in clinical teaching and clinical skills assessment. The first one is time. We're all very busy. We all have very busy schedules. There's lots of patients in the ward, lots of patients in the office, in the ambulatory setting, lots of things to do. And on top of that, us as clinical faculty, we have to see patients, we have to teach our lessons, we have to deal with paperwork, with bureaucracy of our hospitals, of our health system, and that leaves very little time for clinical skills teaching and assessment. Also, we have competing roles, you and me and all the people here that are connected in this session, because we have to see patients, we have to teach, we have to assess. So all these roles are constantly pulling us away from each other's roles. So it's quite a challenge to try to balance these roles as a clinical faculty. Clinical skills teaching and clinical skills assessment with real patients can be opportunistic, which means if I don't know what's going to walk in through the emergency room today, it might be an appendicitis, it might be an ectopic pregnancy, it might be the flu, it might be COVID, we don't know. So we always have to be ready when we're teaching at the bedside and we're teaching in the clinical scenarios, like always have some strategies up our sleeves, independently if we're going to see a strep throat, or we're going to see polytraumatized patient from a car accident, for example. So it's difficult to plan. Another challenge is that we're getting more students every time, every year, every batch, at least in my country, there's more students, and not necessarily more faculty. So that has also becomes a challenge. How am I going to teach, or how am I going to assess all these students if nobody has taken any of my workload away? So finding the ways to do that is always a challenge. Visual recognition, it's no secret. It's actually in most of the medical education literature that the clinical faculty and the clinician educators, we feel little recognition. Like nobody really recognizes or is thankful for our time, that we're overworked, underpaid, and we have all these things to do. And that's trying to deal with this feeling of little recognition. It's something that gets in the way of teaching and assessment. Also, the clinical environment is not very friendly for teaching. It's a very busy scenario. It can be full of people who are in a rush, or you know, the patients might not be very cooperative sometimes, or you know, the health team with, you know, with nurses or the pharmacists, it could be sometimes a challenge to work. So sometimes the clinical environment is not friendly for teaching. So we also have to look for other clinical skills assessment methods, like, you know, like standardized patients or OSCE, or, you know, using other types of methods, not only the clinical environment, even though it's very important. What are some common problems in clinical skills assessment? There are several. One, and I would say one of the most important ones, is not defining the goals and the expectations. You know, a student can come to my, you know, clinic or to my service or to my, you know, assessment day or whatever, and the student might have different goals and expectations than what I have from that student. You know, maybe I want the student to, you know, be there on time and to, you know, go thoroughly through every patient and examine every patient, you know, thoroughly. And maybe the student thinks that we're going to have a very, you know, directed and focused, you know, interaction with the patient. Or like, it's very important that at the beginning of our interaction with students, it could be at the beginning of the day, for example, if we're just going to be one day of activities, or at the beginning of the month, or at the beginning of that specific assessment. What are the goals and expectations for you and from me, and also vice versa? What does the student expect from this interaction? And setting those goals and expectations since the beginning is going to save us from misunderstandings, unmet expectations, disappointments from both parts. Also, the conflict between data and problem solving. For example, you know, we're maybe during rounds, or during, you know, examining a patient at the bedside. And it's not very uncommon. It's very common, you know, for us as clinical faculty to try to assess or to, you know, evaluate the students' knowledge. Like, I don't know, like, you know, asking students, you know, just mere facts when they're in front of a patient, and maybe it could be more useful to, you know, observe how the student examines the patient, or takes his history, or performs a physical examination, or like, instead of trying to solve the patient's problem, us as clinical faculty, we're trying to just to pull information, you know, just facts out of the student. That's maybe not the right time for that. Maybe that was the time for that, the classroom, or back when they were in the preclinical years. Right now, how can we help students solve problems from the patients, and how can we assess them on that? So that's always a challenge, because that's probably the way we were formed and educated when we were in med school, you know, just spitting out facts and spitting out different, you know, information, and reciting the Krebs cycle in the middle of the operation room. You know, what's the value of that? You know, so trying to solve problems might be something more useful for the students. Lack of supervision and lack of feedback is a very big problem. Like, all our students are, you know, in these clinical scenarios, in the operation room, or in the wards, or in the emergency room, or in the clinic, and they're not being supervised. You know, they are forming their clinical skills, but with very little supervision. And what's worse, with very little feedback, almost no feedback. That lack of supervision, or maybe, you know, we just let the students run around, you know, being supervised by the resident who's very busy and has no time, or maybe doesn't have the exact knowledge of supervising and giving feedback. So what are the students gonna accomplish there? Well, they're gonna probably keep making the same mistakes, or they're maybe are gonna develop skills that are not necessarily the best ones. So always supervision from faculty and feedback is always a good strategy. Little opportunity for reflection and discussion. Like, we have very busy days in the clinic or in the ward, and we're seeing patients, and I'm, you know, trying to assess how my students' clinical skills, history taking, whatever, are, you know, how they are performing. And there's little opportunity to sit down and, you know, how do you feel today? Like, do you think your skills are improving? Do you think you're in a better place than when you got here in the first day of your rotation? Like, all of that is going to, not having a space to, you know, just make a pause for 5 minutes and try to discuss how the students are doing. That's always going to be a positive thing for the student. Obviously, teaching through humiliation, it doesn't work. Telling the students that they're not good, or that scolding them in public, or or trying to make them learn through humiliating them, or pointing out their deficiencies or their mistakes in public. That doesn't work. That might have been the way somebody did it to us, but it's definitely not the way that we should be practicing anymore, teaching and assessment. This is one of my favorite errors, the pitching error. So, for example, sometimes we have students from different levels. Maybe we have we're about to examine a patient, and we're rounding, and maybe there's the 5th-year student, 6th-year student, 1st-year resident, 2nd-year resident, even up to fellows. And sometimes we want to ask a student a question, or we want the student to perform an activity that's not fit for his level or her level. And we ask the student a question, and the 5th-year student doesn't know it, the 6th-year student doesn't know the answer, and we go through all the levels of the residence, and only the fellow knew the answer. Well, that's probably a poorly stated or framed question or task, because nobody could do it. And then we get angry at our, like, how is it possible? Examine the eye properly. Maybe that task or question is not properly set for the level of that student. So we're going to talk a little bit more about that. Can you guys hear me okay? Because I just got a sign that my connection is poor.
Yes.
Can you hear me?
For a few seconds, we lost you. Now we are back.
Okay, great. And we're going to talk a little bit more about passive observation and active observation. Sometimes we want to teach, we want to assess, but students can only observe because of the nature of that. Maybe it's a very complicated surgery or a very complicated patient, or there's lots of students. We cannot make every student participate and assess them. Or we're going to talk a little bit more about active observation. Another thing about assessment in clinical skills is reluctance from faculty, from us, to assess them in a quote unquote negative way. Like, we don't want to give them, a bad mark or a low mark or a low assessment, because, it's clinical skills. If they're taking history, or they're examining a patient, or they're, we don't want to, affect them. And sometimes that can hurt the student more than it can help the student. This is a worldwide problem. Teachers are normally reluctant to document a negative assessment. Like, they're reluctant to, poorly, assessing the student in a deficient level, or in a, needs to improve level. We always want our students to be the best ones. And sometimes we say they're all good kids, they're learning, and we're always just ticking off the boxes of the evaluation, of the assessment forms in excellent and very good, and like, but does that really help the student? And for us, if we assess all the students always in excellent, very good, we're gonna find a couple of things. First, we're gonna find that we're not gonna be able to discern the student that's competent from the one that's not competent, or that's in development. Second, we are sending the message to our students: you are excellent, you are great, you don't have anything to improve on. And that's a very dangerous message when we are trying to form medical or health professionals. So the fact that our faculty, and this happened to me a lot with my faculty, and we've tried to work a lot on this. The fact that the faculty assesses everyone as great, excellent, wonderful in their clinical skills doesn't mean that they're not able to identify which students are at risk or which students need to improve. They know which students need to improve and which students are at risk, but we choose not to differentiate the students and just to pretend that everybody is excellent and wonderful. What are some causes for this reluctance to give quote unquote negative assessments? First, well, we are afraid that the student might be, angry at us, or he's gonna go and complain to my chair that I gave him a bad mark in his clinical skills assessment, so I rather just save me the trouble, and I'm just gonna, assess everybody as excellent. We also have a belief the student is on time every day. He's very respectful. She is very kind to her patients. So she or he shouldn't receive a bad assessment or an assessment that's not excellent, because she's a very nice person. Also, sometimes we don't feel the institutional support. Like we feel like, okay, the student, I think there's a lot of room for improvement. I have this assessment form in front of me. I'm going to write down in a couple of skills or competencies that this student needs improvement or is deficient. But then what's going to happen is that in my institution, nothing is going to be done about it. There's no remediation program. How is that student going to improve? Who's going to accompany the student in a plan for his improvement? Or maybe the student is going to complain, and then the chair or the department head is just going to make a new evaluation form with great and excellent and good work. So sometimes we feel like our institution doesn't support us to really be honest in these assessments, or we don't want to get involved in if I write down in this assessment form that the student is deficient or in progress or development and it's not excellent, they're gonna have to call me into this committee to help the student, and I don't have time for that. So I rather just have an assessment as excellent. We are afraid that we're going to be poorly evaluated as a clinician, faculty, or as a clinical educator, because we also need to. Students sometimes they evaluate us, and we're maybe up for a promotion, or we want to apply for an award, and if we get poor evaluations, then that might affect us. So that's why we just want everybody to be excellent, so they can also tell me that I'm excellent, and we all live in this little fantasy. Also, sometimes there can be conflict in the role of mentor and the role of evaluator or of assessor, which means like this student, I'm their mentor. She comes to me for several issues, and how am I going to tell her that she's deficient if she's my mentee? Anyway, so this is a very, very common thing that happens. There's been studies which 82% of clinical teachers do not feel comfortable with evaluating both badly, because there's high expectations of students. They are afraid that maybe the students might take legal actions or they might complain. So people just avoid it, Even they've surveyed directors of clinical clerkships, and 43% felt that they don't have the necessary information. They don't trust the clinical skills assessment forms, and they don't know which student is competent and which one is not competent. Even though everybody graduates, being honest, most of these clinical clerkship directors, they don't feel they have the necessary information to assess which student is competent and which one is not. So this is why it's so important to have a solid and robust clinical skills assessment program or method in our school. Just a survey of like, most people believe that grade inflation or not being honest in the assessments is a big problem in most of the settings. Okay. Please, if there are any comments, like I want this to be, interactive, and if there are any comments or any questions, just raise your hand, open your microphone. You don't have to wait till the end for questions. We can make this a conversation. That's fine. Questions, comments, remarks before we go on?
You can leave comments in the chat box. And I can ask. Yeah, please, ma'am. Please, ma'am. Our Director of Academics has a question for you, sir.
Cesar, how do you handle this negative feedback from the students as a fear? As you told, no, it's a worldwide problem, but how do we handle this situation, Cesar?
Like, you mean the situation where students are gonna evaluate the faculty as poorly because they got a poor assessment?
Yeah, Cesar.
Yeah. So first, what we do in our institution is our clinical skills assessment, we do it through an app that we design. So it's not on paper, it's digital. And the student evaluates the faculty blindly. So for example, I assess Vinuta because we saw a patient together or we had a little mini CX together. I do her assessment, gets an email that I just assess her. And for her to see her assessment, she needs to assess me evaluate me as a faculty first. So she's going to get the link that says, here's your assessment, in order to, you can see it at the end of the rotation, or you can see it now. If you want to see it now, evaluate Dr. Lucio. So she's going to evaluate me, and then she can see her assessment. That's one way we've, bypassed this problem. The second way is to get to really get on board all of the clinical faculty, all of the clinical teachers, everybody to have access to assess the students. So that way, maybe Vinuta gave me a bad assessment or a negative evaluation, because I assessed her poorly, but I have all these other 20, 30, 40 students who are also evaluating me and really want to affect me. And it also goes both ways. And that's a way that we reassure students, because students are very worried about their mark, about their grade. They're super worried. They have scholarships to maintain. They want to go into the best residency programs. They're under a lot of pressure. But we tell them, not just because Dr. Cesar assess you in a deficient way, it's really not going to affect you, because you're going to get not 1 or 3 or 4, you're going to get 20 or 30 different assessments during your pediatrics rotation. So you're going to have room for improvement. So that has students a little bit at ease that everything is going to be fine. Because, before we started doing, a programmatic assessment way, it was the old, I don't know how it's done at your institutions, but the way it was done with us up to a couple of years ago, it was the student was in a rotation, let's say pediatrics, for 3 months. And at the end of the 3 months, they went to the clinical clerk, to the clerkship director, or to the department head with a little form, and the department head would fill out the form, and that will be basically their only assessment, or maybe once per month. So we've changed that to happen as often as possible, and that's giving us good results.
Thank you, Cesar.
Thank you. So we're gonna talk a little bit about another concept called, and I'm sorry if maybe some of you already know about this concept, but it's called the zone of proximal development, or we call it the learning edge. We're gonna talk a little bit about this. So in this model, our current knowledge, but I, Cesar, can do without help. For example, I already know how to, I don't know, place, examine a newborn child and give him a newborn examination. I can do it, no problem. I know what to do. I can do it without help. Then in the next zone is what I can learn or do with help. Maybe I could learn how to place a central line. So I haven't done that in a long time. So maybe if somebody can help me, I can, reunite the knowledge and the skills, and I could learn how to place a central line. That's feasible, that's possible for me. I could do it. Somebody can teach me. And then in the next level is what you don't know, but also it's out of reach. There's no way you can know this. It's very difficult you can learn this. For example, if I could, perform a appendectomy on a child. I don't have the skills for that. I wasn't trained for that. I don't know how to do it. Even if somebody walks me through it, it's not going to happen. So the zone in the middle, what I can do with help or what I can learn is called the zone of proximal development. And this is the sweet spot. This is where we want to keep our students engaged, involved, assessing them here, because sometimes we either want to test them or assess them on the same stuff as every day, the same stuff of all year long. We're just, to even though they're important skills, but just the chest examination and the cranial nerves, and we always focus on the same stuff. But also some clinical faculty or some clerkship directors or whatever, they want to assess them over here, like what a 5th-year medical student. We want to test them, and we want them to learn what a 4-year resident in internal medicine needs to know. There's no need for that. Like, let's not lose any time trying to teach them concepts or skills or abilities. Like, for example, there's no point in me trying to teach a 5th-year medical student how to place a central line on a newborn. There's no point with that. They're not going to do it. It's not feasible for them. It's not for them. It's not something we want them to learn. But if we keep them in this spot, if we try to assess them on the next step and try to assess them on always being just one step ahead of them, it's going to make much more sense for them. And we're really going to help them improve gradually across their formation. So let's always try to stay in the zone of proximal development. What can they learn and what can they do with help? And this is a never-ending area, because we can always learn something else. We can always do something else with help. We never stop. So if we always stay in this spot and we try not to be in the other 2 spots, they're probably going to make more sense for the students. And I wanted to talk to you about some necessary elements for clinical skills teaching and clinical skills assessment. First, prefer learning over performance. Sometimes we're very oriented towards the student, performing perfectly in their physical exam or their history taking, okay, that's fine, but let's rather focus on learning. What can the student learn? How can we help them learn the next stage in their zone of proximal development? And not how can they get it perfectly every single time, which is not going to happen. Once again, try to assess for learning and not assess what they have learned. This is a very difficult concept that probably most of you already know, but like, assess so they can learn, not assess strictly what they know and what they do not know. Focus it only on what they know, what they do not know, can just lead to frustration, to grades or marks that don't really translate into learning. But if we try to transform assessment for learning, so we try to design an activity or a method so students can be assessed, and that could be a vehicle for learning, that could be that can have better results. Obviously, us as clinical faculty, we need to know what are the learning objectives and the assessment methods. Like, we need to do our homework also. We need to sit down and say, okay, in this pediatrics rotation, what do students need to learn? Because sometimes maybe I might be new to the program and I want the students to learn things that are not really in the program or that are not really in the learning objectives. Maybe I want them to be independent in, doing tracheal intubation when what they need to learn is just to perform a physical examination on a well child. Okay. Try to challenge the student to develop their own learning strategies. Try to help them being independent and help them in any ways they can learn, specifically, not as a group. And follow the word is not tracing, is following up. Doing a little follow-up on the students is important. Okay. Sometimes we cannot assess the students because there's no time, there's no, or the task is too complex for the student, and they only have to observe. And that most of medical school, we go through it just observing, watching a surgery, watching the clinical educator, the clinical teacher, interact with patients, watching the faculty do a procedure or the resident do a procedure. So observation is often not very desirable. It might not have a lot of impact for the student. There's little chance for feedback. But it's useful when there's no chance for the student to participate. We want students to be active in learning, to participate, to solve real problems. But when there's no chance to do that, there's other ways that the student can observe that it's not just passive observation. You know, because observation has been the method. Students have been learning medicine since ancient times, since the Greeks or the Romans that were just, you know, watching the professor, you know, perform a physical examination, or in the Byzantine Empire, you know, all the medical students watching the professor, you know, perform suction cups, or watching the professor, perform a abdominal as a student, by the way, looking at the patient. In the medieval times, you know, the students watching the faculty. In the early 1900s, that's Sir William Osler, you know, doing a bedside examination and all the students just watching. This is Dr. Cushing also performing an exam and all the students watching. Even in our modern day era, we're just, you know, observing. So how can we teach clinical skills when students are just observing? Okay. This is a quote that I like, you know, clinical teachers need to make students' observational experiences as active and productive as possible, helping them not only to see what's going on at a surface level, but also to be aware of the thinking activities that are hidden from the view. So the student can be observing, but there's a lot of thinking going on in the student's head that we need to take advantage of. First, we shouldn't assume that the student is going to observe and is going to see the same things that we see. You know, I may be, examining a patient with, you know, heart failure, and maybe I want the student, maybe I'm seeing, you know, the jugular ingurgitation, but maybe the student is focusing on the patient's hand that the IV is not properly placed. You know, so we always need to assume that the student might not be seeing what we want him to see. Okay. Also, we need to know that there are different ways to observe the same situation. You know, maybe our first-year student, our fifth-year student is going to be observing during the surgery, you know, how the nurse is passing the instruments to the surgeon, but maybe the first-year resident is going to be focusing on how the surgeon is, you know, performing the incision. So depending on the background, the experience of the observer might notice different things. Also, when there's a lack of structure, when I just tell the students, you know what, you're going to sit there and you're going to watch me work, or you're going to watch me examine a patient, there is danger that the student is going to try to observe everything. He's going to be trying not know where to look, not know where to, just confused, and he's going to see everything at a superficial level. And he might not notice what we wanted him to learn. Maybe asthmatic child came into my office, and we really wanted the student to notice the, you know, the respiratory distress, but maybe the student is, you know, watching everything else. So we need to be specific about what do we want the student to observe. Because clearly the instruction, look or observe, is absurd, because observation is always selective. You need somebody to tell you, observe this object, observe this task, this point of view, this problem, for observation to make sense. So how can we apply active observation? First, we need to specify to the student, okay, we're gonna see this patient, it's too complicated, we don't have time for me to assess you, but I want you to observe this specific trait of the patient. I want you to observe how the patient walks. I want you to observe how the patient talks. I want you to observe, when I'm examining the patient, you know, the lesions on his chest. And I want you to observe it for this purpose, because I want you to learn about the different rashes in the exanthematical infections in kids, for example. Another way, other than being specific to the students, is to ask the students to take, I always ask my students when we're seeing a patient to take notes in a very, ask them to get a very small, you know, notepad and very discreetly take notes. So we're going to go into this patient's bed. there's 10 medical students. Only one medical student is going to examine the patient, but the other 9 medical students, I want you to, as we start the interrogation, to write down your differential diagnosis. Or write down a list of all the medications the patient is going to tell us he's taking. Or write down a list of all the symptoms that the patient is saying and try to integrate the diagnosis. Or we're going to do a history. So try to identify the risk factors of the students, of the patient. So even though they're just observing someone else doing the task, they can very discreetly take notes, and that's going to help them, make an exercise in their mind about what they're observing. So that's always a good practice. And of course, having a space for reflection and discussion. Okay, we had a very busy day at the clinic. We saw 20 patients today. You could only participate in 1 or 2. Most of them you just observed. But what happened during this interaction that changed the way you see the patient? What do you see today in this office that you would apply to your practice? Just have 5 to 10 minutes at the end of the day, and try for students to reflect and to have a little discussion about what they've learned, what do they take home, and how did this day or this student or this patient impacted their practice. Talking about students observing, I'm going to share with you 5 rules to observe the student, for the students to observe, okay? First, positioning. It's very, everybody can see each other when the student is going to maybe be there with a patient, and we're going to try to observe the student participate. Maybe if we're in the clinic and I'm facing the patient and the student is behind me, facing my back, it's going to be very difficult for that student to participate, to go ahead and examine that patient's abdomen or examine the patient's chest, or maybe throwing a comment. So something as easy as positioning the student in a way that student, patient, and me can all see each other, that's going to detonate student participation, and that can help us assess the student's skills. Okay, so the position of the student is very important. Never in the back, never, always at the front stage, close to the patient. Second, if we know that we're going to try to observe a student work, or if we know that we're going to try to observe a student do a task to assess him, try to minimize interruptions. Maybe turn off your cell phone, maybe ask the nurse in the entrance not to let any visitors come in. Try for that student to perform the task for 5 to 10 minutes without interruptions, because interruptions can throw the student off and can maybe interfere with the interaction and with the skills we want to assess. Try to avoid interference. Like, try not to interfere. Like, maybe the student is performing a physical examination, or maybe the student is performing a history, and maybe he or she is not doing the best job. Maybe he's made a couple of mistakes. If it's something that you could pass, that you could just let go for a student to continue, just let it go. It's not urgent. We're always trying to jump in and correct what the student said and correct what the student is doing. If it's something that is minor, just let it go. Try to keep the student, keep examining or to keep questioning the patient, and try for the student to have a beginning and an ending in a manner that it actually has a flow. Okay, but it's something that needs to be corrected or needs to be clarified. If there's no other way, well, then you can interrupt the student. But if not, try not to interrupt. Try to be prepared. For example, if you're conducting rounds and you want a student to perform a task, try to be prepared as in what does that student need to learn in that rotation or in that clinical environment. Like, maybe we need to focus on the student to, I don't know, examine the ears of the middle ear, or what. Well, maybe then try to focus on that. So instead of just asking the student to make a full history and a full physical every single time, maybe try to be prepared of what is the student going to do now. How can I relate this to the learning objectives of the course? Also prepare the student. Let the student know what he is going to do or she is going to do. Like today, you will examine a patient's abdomen, or you will, identify the risk factors in a patient, or so the student is ready and not nervous and not anxious of what he's going to do. And trying to also get the patient ready. Okay, Mr. Smith, this is the medical student X, and he is going to examine your abdomen. He's going to help me examine your abdomen, or he's going to help us question you about some risk factors that we want to, discard. And the patient also needs to be part of this when we're observing students work and we want to assess their clinical skills. So a correct positioning of the student, minimize interruptions, avoid interference, know what is going to be assessed or what the student needs to learn, and prepare the student and the patient. These are the 5 rules to observe the student work, so we can make a fair assessment. This is the last part of my talk before we go into any questions. We're going to talk about feedback. So, maybe we did a great assessment and we filled out the form, or we did a mini CX, or we did the DOPS form, or we just finished an OSCE. But if we don't end with feedback, or we don't have time for feedback, that's not going to have as much impact as it could for our students. So this is an article that I like that is called that we are starving our young doctors from feedback, because they want to receive feedback. They want to know how they're doing, but we normally don't give it to them because we don't have time or we don't know how to do it. So feedback is the most powerful and impactful teaching strategy for students. This is where it's going to make sense for them. This is where everything is going to actually come into integration when we tell them how they did, what can they improve, and what they need to keep doing better. When we talk about feedback, we talk about an informed, non-evaluative, and objective judgment or appraisal of a student's clinical performance. We need to have, when we're going to give feedback, we need to keep 3 objectives in mind. Either improve the student's skills, modify their behaviors or attitudes, or reinforce their strengths. When we're going to sit down and give a student feedback, we need to focus on these 3 questions. Are we going to improve their skills? Are we going to modify their behaviors, or are we going to reinforce their strengths? If we're not going to do any of those 3 things, and we're just going to scold them, or we're just going to make them, feel like they're not good, or we're just going to, give very general appraisal, like, good job, keep it up, then that's not feedback. That's just, comments or a scolding or something else. But we always need to keep these 3 objectives in mind. When does feedback fail? It's very common that we just made an assessment on the student's performance or their clinical skills, and we want to give them feedback. It's very common that it didn't work. The feedback didn't work. First, maybe it was poorly managed. Maybe we didn't know how to give feedback. Or maybe if I approach Vinuta and I told her, Vinuta, into my office, you and me have to talk. If I tell her that, she's going to maybe become defensive. What did I do? Why is he asking me that I need to go into his office? What do we need to talk about? Am I in trouble? And that might be a bad way of starting feedback. So try to not put students into a defensive way. Another is that the student is exposed or embarrassed, that we are giving them their feedback session, quote unquote, in the hallway, at the nurse's station. Maybe we are, being rude or impolite or aggressive, and that is going to just make the student just hide in a shell, and nothing is going to go through. When they are rejected or demoralized, when we are telling them they're no good, that their performance was awful, that how Are they going to graduate into competent doctors with that kind of performance or that kind of physical examination? That's not going to help. That's just going to make the student not learning anything. What we talked about at the beginning, when there's different goals or perspectives from the teacher, from the student, also that normally there's going to be disappointment from the performance of the student from us, or there's going to be disappointment of what the students achieved. So we always need to have the same goals and perspectives in the students. When we start blaming, people also, that's not feedback, that's just something else. So what are the characteristics of effective feedback? So after we assess the students, we give them a mark or an assessment of their skills, and we want to give them feedback. We need to do it in a safe environment. It has to be two ways. We have to give feedback to the students, but also we need the students to give them a chance to tell us how they feel. It needs to be in private. We need to agree on what are the goals and the expectations of this feedback. Like, Minuta, we're going to have a 15-minute conversation on your performance. And at the end of this session, I want you to realize what are your strengths and what are your points that you need to improve. That's a good way of starting, and to agree on what are the goals of this session. It needs to be regular. If it just only happens once in the whole pediatrics rotation, that's very little. It needs to happen, in at certain times, over and over again. It's important if the students start with a self-assessment. We're going to see a model for that. We need to make observations that can be corrected. If I tell the student, and my feedback is, I don't like the way you talk, I don't like the way you dress, I don't like the way you walk. Well, some of their observations might not be very feasible to change. I talk how I talk, that's my voice, or that's how I walk, So try to focus on stuff or on observations that the students can actually improve on. It has to be focused, not a lot, 1 or 2 observations. Sometimes we want to tell the students a lot of things to improve. And you need to improve the way you examine the eyes. And you need to improve on the way of how you talk to the patient. And you need to improve on your clinical judgment. And if you tell them 10 different things, the student is just going to be able to process 1 or 2. So try to keep it short and sweet, okay? Let's use peaceful, neutral language. Make sure at the end of the session, the student understood the plan, and try to make an action plan at the end. This is my last slide. This is a feedback model that I like. That I don't know if you guys, you probably have heard of lots of different models. The sandwich model is a very famous model where there's the bread, that is a good thing, the meat or the ham, that is a negative thing, and then the other bread, which is a good thing again. That model works, but we've seen that they normally stick with just, what stays in the student's mind are just the breads, and they didn't really care about the meat. So this is a model that we like, the Pendleton model. So first, ask a student to start with a self-assessment. So Vinuta, how do you feel today? How do you think your performance was today with the patient? To get the student to do a self-assessment right at the beginning. It has been studied, and most of the times, the student self-assessment is going to match what we were going to tell them anyway. Okay, but it has way more impact when it came out of the student than we came out of us. So how do you feel? Well, Vinuta's going to tell me, well, I think I was nervous because when I was examining the patient, she had pain, and I didn't want to hurt her. So I think that's why I missed, palpating the liver, for example. Maybe that's the same thing what we're going to tell them. But now that it came out of Vinuta, it's going to be easier for her to process what she needs to improve on. Or, you know what? Yes, I think the differential diagnoses that I thought about were not the best ones, because I haven't read about this topic in years, since I was in the preclinical years. So maybe I need to learn about that more. So it was the same thing I was going to tell her, or something very similar, but when the student, it comes out of them, it's better. So anyway, they start with a self-assessment. Then we reinforce what they said. You know what, Vinuta, you're right. I also noticed that you didn't palpate the liver. So next time, try to always do it in order and try not to skip any steps when you examine the abdomen. Or you know what? I also noticed that your differential diagnoses were a little bit odd. So why don't, I think you're all right that you maybe need to work on your differential diagnosis of abdominal pain, for example. So we reinforce what they said and we tell them, you are right. You need, this is what probably needs to be improved. And then remember, this is a two-way model. And then you throw it back at the students. Okay, so now that you tell me this, Vinuta, what do you think you could do better? What could you do different? And then maybe the students are gonna tell me, well, I think that I need to go back to my notes and learn about and read again about abdominal pain, or maybe next time that I examine the abdomen, I'm always going to give the same order so I don't forget. So the student, not us, the student is going to tell us why they need to do what they need to do better next time. And then at the end, the two of us together, we're gonna make an action plan. Okay, you're right. I think that's what you could do better next time. Why do we do this? Go and read up on abdominal pain. I'm gonna send you a couple of review articles on the topic. And then tomorrow or the next week, we're going to examine a similar patient and we're gonna do it all over again. Or you know what? You're right. Why don't you go to the simulation lab and try to practice that skill over and over so you're not so nervous next time. And then next week, we'll do it all over again. So if we do an action plan, that makes the student accountable of how to improve their skills and how can we do it again and how could the student improve. So first, the student self-assessment when we're giving feedback, then reinforce what they said. At the end, what could they do better? Get them to say it. And then at the end, make an action plan that actually works for both parties involved. I think that's my last slide, right on time. So I'm open for any questions or comments that you would like to share with us. And I thank you, Vinuta, and all people involved for this invitation. I'm very glad that I'm here.
Thank you, Cesar. And I really thank all the participants for us, it's late evening after work. In spite of that, like so many of you have logged in and been participating. And I see stalwarts in medical education being here in India. Cesar, I would like to tell you that we have eminent medical educators from all over India being present here today. Before I actually, there are a few questions in the chat box. Shall I take them, or people who are having questions can raise your hands or leave it in the chat box, or else I shall start asking. Do you have 10 minutes, Cesar? How long can you spare time for us for the question and answer session?
Yes. We can do another 10 minutes, yeah.
Yeah, so I will ask these questions accordingly. One is based on, do we need to, like how OSCE, OSCE has been used as a teaching learning technique for clinical skills. Can it be introduced for this particular assessment that you're talking about is one question.
Yes, it can. Actually, in our institution, we used the OSCE strategy since first year. Like at the end of the first semester and second semester, they have an OSCE or a mini OSCE, if we can say like that, on very basic skills, like just not even the whole history taking, just like identifying risk factors, or just asking for several parts of the history. Or in the second semester, we have an OSCE with them of just a very specific task. Like they don't have to, reach a diagnosis, do a whole history and physical, reach a diagnosis, make a note. They can just do it on examining the chest, for example, which is, so yes, we can do an OSCE in all different levels. It's just a matter of adjusting remember the zone of proximal development. What do you want them to learn? And it's a strategy that can be used. It's not perfect. It's not the only one, but it's something that is always, especially in the earlier years, when the students get an experience in which they in front of them, there's a standardized patient or an actor, or even just an older medical student that is posing as a patient, and they get to do a very specific task. They really enjoy it. They have a lot of learning from that. So I believe that we use it at every level for sure.
Yeah, I think the entire key message for today's session is the zone of proximal development that you talked about. That's really interesting. Like, don't you think it's like similar to the milestones of indispensable professional activities that we say, like at
Yeah,
what
for
level
sure.
they need to acquire all skills? So that was very interesting, and I think that particular slide is really etched in the memory. One more question is: at present, formative clinical assessment is not well taken by students because it's not added for their promotion to the next year. How to overcome lack of student participation in frequent workplace-based assessments? Basically, I think the question is how do I address demotivation with respect to frequent workplace-based assessment in postgraduates?
Well, I mean, there's several strategies. We had the same problem. We attacked it on several fronts. First, all these that we're talking about is formative assessment, right? It's not summative assessment. Like, this is not an exam with a grade. It's formative assessment, but we gave it a little percentage of value towards their final grade. You know, even if you give it a 5 point out of 100 value of their final grade, like, they will take it seriously because they all want 100. They don't want a 95. They want 100. So just if you give it a little bit of value, like, your formative assessment, participating, delivering, delivering your forms, participating in the OSCE, and your performance is going to have a small ponderation, that works for them to be a little bit engaged. If you cannot do that, I mean, all the other tools that I share with you, like, making them active participants, making them solve real problems of the patient. Like, if you have a patient in front of you, and I ask you to solve a problem, if you don't want to do it, then you're maybe not very fit to be a doctor, because that must be, coming out of you, like, you want to help, you also giving them a little bit of independence, a little bit of, you're a young doctor now, go and do this task. I'm going to supervise you from afar. And that always gets students involved in not just observing, because it's the observation part that always like, skills learning. That's just, just go to this long day at the clinic and just, walk around observing. That if we can avoid that can also get them engaged and work. And as you said, workplace-based assessment is what we're talking about right now. Like, assessing them as they go during their day. That's a good way of doing it.
Yeah, thank you. I think, yes, that active observation is something that each one of us have to like sort of practice, because observation is one thing, like even our skills mandated by our policymakers says demonstration, observation, assistance, and then final performance. So this observation should be active observation. I think we need to stress. And we have one more question in the chat box. How do we get to know if a student is ready to get assessed? And how many attempts a student should ideally be given to perfect the skill to be learned?
That's a very good question. First of all, how do we know if a student is ready to get assessed? Well, to be honest, if the thing is that we need to, in certain ways, we need to stop thinking assessment as a single event, high stake, win all, lose all event. If we see assessment like that, the student is never going to be ready. They're never going to be ready. Not even when they're graduating residency. But if we see assessment as something that happens several times during their formation, multiple times from multiple faculty, then it can happen at any moment. It can happen on day one. You could just formative assessment of how you're doing, give you feedback and, get better for tomorrow or the next week, So if we assess them several times, several people do across time, they're always ready, like, because it's just part of their formation and going. And how many attempts should a student be for it? So it's very hard to answer for a specific skill how many times they need to be assessed. It's very hard for a specific skill, but for their overall performance, let's say, how does the student perform in a clinical setting in surgery or pediatrics? Normally, a good amount of assessments across the rotation will be between 6 and 8. That's something that, we have a fair amount of observations, of assessments, and we can say, that's the student can be overall competent as in, in clinical skills. For a specific skill, it's hard. It depends on the student's level. It depends on how you're teaching the skill. But for a whole, experience or rotation, 6 to 8 could be a good number.
Yeah, as a continuation of this, like there's one question, is it necessary to give feedback every time they're assessed? Like you said, 6 to 8 times. They want to know, should every assessment be associated with feedback?
Yes, I would say yes. And think of feedback as as short sessions. It could be a 2-minute feedback, just with the model that I just showed you. You can give it in 2 minutes or 3 minutes. And that's better than just giving the form. The student reads the form and that's it. It's way better if you, every assessment you make, you give a small, directed, focused feedback that's going to have way more input for the student.
Yeah, one from Dr. Raghu, you raised your hands. Can you unmute and ask a question?
Yes. Yes, madam. Thank you. I just have one question. Like if you are, usually there are multiple teachers will be there in each subject, and each one's perspective regarding the assessment will be different, and each one's expectations regarding how much the student tells will be enough. So will be differently. They will be very much different. So how do you assess the student in this scenario, in this condition? Because once a student will get a positive assessment from one teacher, and at the same time you'll get a negative assessment from another teacher whose expectation will be very high. How to tackle with this?
Well, first, students need to know that they're being assessed by human beings with different opinions and perspectives, and with for example, it's already described in literature that very senior faculty assess differently than junior faculty, for example. So, but even though if the student is aware of that, we still need for faculty to be trained in assessment and observing, because if we just have a very big hospital and there's 20 pediatricians as observing students and assessing them, and the students, like you said, might get confused, and they might even go complain. Like, I have 2 assessments from 2 different faculty. The one is saying that I'm awful and one says that I'm excellent. So faculty development is crucial. Like we call it calibration of the faculty is very important. Like, organize a workshop where, these are the zone of proximal development that we want in our students. These are the objectives of the course. These are the skills that they need to know. A 5th-year student doesn't need to know how to press a central line. A 5th-year student needs to know how to examine a baby. So a good faculty development workshop with all these concepts of active observation, of how to observe the students, what they need to learn, what are the objectives, and also maybe do an exercise. For example, in my institution, I made a video. I made a video with a student, examining, and I was doing, when we were simulating an assessment where the student was examining a patient, he's taking the history of a patient, and I was observing a student. And first, we had a student do a good job, and then we had another, and then we had the faculty observe them, And no, sorry, we had the student do a very poor job, making mistakes, not examining properly, etc. So this is what I do. This is I urge you to do this. I made 2 videos. The first video, the student was behaving poorly. And then after the video, I asked all of the faculty to assess the student with our forms that we used. And everybody, this student is horrible. This student is, in all negative assessments. And then after that, I showed them, I gathered all of the assessment forms for the past 5 years in our institution. And the average of each skill and each competency was 9.99 out of 10. Consistently throughout the 5 years, all those faculty that were being very strict with that video were consistently just evaluating excellence. Okay. So then I show them their own evaluations. Like, you're telling me that this student is very poor, which is a normal student that has mistakes, but on the other hand, you're assessing them as perfect. And that's a real eye-opener for them. And then after that eye-opener, that they discover they are super strict with the video, but super lenient with the real students, I show them another video with a student performing like we want them to perform, doing a full physical, interrogate or questioning certain aspects of the history, and then I ask them to assess the student again. So that exercise helped them realize two things. One, that they were being over lenient, and two, it helped me. And then they had a discussion. Like, do you think this student's performance is what we need to assess? And once we got an agreement, a consensus, then our assessment form started to change. You know, the professors who were very lenient, they started to to assess more normally towards reality, and people started knowing what they had to assess. And then you had to maintain that faculty development sessions once every 3 months, starting to go back to the faculty and starting to, as a group, starting to move of how do we want to assess the students. So it was a very long answer, but in a nutshell, faculty development for the faculty, so they know how to assess and where are they standing right now.
Thanks. So we have 3 more questions. I think we'll take 3. Rinku, Dr. Sanjay Bedi, and then finally Elsa. Dr. Rinku, can you please unmute and ask?
Yeah, hello, sir. Sir, I just had a doubt that I am a teacher or a professor for forensic medicine, which is a paramedical subject. So now here, how do we put the OSCE? OSCE doesn't work over here. OSCE works over here. Practical examination. So how do we put the stations over here? Like, how do we formulate the stations?
That's a very big question for
yeah, because we don't have even practical activities.
Yeah,
so does OSCE or OSCE work in?
So what I would say is try to keep the stations as close to real life as possible, even if they're second year students. Like, what skills do you want them to examine organ, or do you want them to maybe even it could just be in a piece of paper. They could just go in a station, there's a piece of paper in front of them that's telling them an information or a case or something, and like just try to make as real life as possible, but also very oriented to where your learning objectives. Like, don't go anywhere, try not to go too beyond. And even if it's just, and also you don't have to do all 9 stations. So sometimes we do OSCEs with 2 stations, 3 stations, that's fine, but try to think, how can a student solve a real life problem within that station, and how can we assess the student? Like, I know it's hard because, a dead body is not gonna talk back. Maybe if you have a simulation department, try to go to them and they can help you out. Just try to keep it as real as possible.
Thanks. Last 2 questions.
Okay.
Dr. Sanjay Bedi, please unmute and tell.
Sir, thank you for the excellent talk, and you have just touched many important aspects, and many of these problems. I mean, it was nice to. I mean, it was revealing to me that it is a national and global problem. So,
how did she reach school?
And how do we move? Can we? Is there a role for technology?
Okay,
with a big T. I mean, the student comes and he is provided with certain basic videos with questions, continuous basis. There are questions, and there is some artificial intelligence also involved in it. And part of the role of assessment is shifted to technology, and the final assessment is only given to the teacher. I mean, those repeated assessments.
Sorry, I had a hard time. I think I lost a bunch of the question. Can you just summarize it for me?
I will summarize. Sir wants to know if technology can be used for assessment.
Yes, for sure. In a bunch of different ways. just the mere fact of going paperless, something as easy as that, just going paperless can really boost. Because for example, in our case, like we went paperless, but we also went real time. Like I assess the student and the student gets their assessment immediately. So they know what to work on. Another example, for example, all the assessments are being captured in a dashboard where, for example, there's 3 different people who can look at the dashboard. For example, the student, he can look at how their skills are performing throughout time. And maybe, differential diagnosis is consistently being poorly assessed. Well, she knows without nobody telling them anything, she knows what she needs to improve on. Or for example, a closeship director can see in the dashboard how all his faculty are assessing. And if he sees that Vinuta is consistently assessing in a very poor way, no student is good enough for her, she's doing very poor, well, maybe we can approach Vinuta and try to train her and invite her to the faculty development session so she can improve her assessment skills. Or maybe the student receives also in the dashboard, for example, all the narrative, because also the faculty or the teacher fill out the form, but also types narrative feedback, like a little comment. And the student has all the comments in one place. And the student can see, I'm getting constantly comments of that I need to improve my communication with patients, for example. Well, then the student knows what does she need to improve, because several people are telling her the same thing. So technology, there's a huge area of opportunity to take advantage of that. Also analytics, like we can try to, as a program or as a curriculum, try to see where the students need to improve and how can we change that. So the sky is the limit when technology and assessment interact.
Yeah, for what you're telling, Blackboard for Learn is a good LMS somebody is suggesting for what you've been telling, the dashboard thing. One question, Cesar, before we wind up, and then finally, Elsa says OSCE stations are like a good answer because they provide broader sampling and it reduces time and workload. And one question was the peer-assisted learning. Do you allow seniors to assess juniors, and do they also be a part of this formative assessment?
Yes, that's always helpful. Peer assessment, and maybe a resident can give feedback to the students and whatnot. That's fine, and that's very helpful. That can happen, but we should also have a responsible person in charge of the assessment, because this is also we should, because what I found is that peer assessment, if we give it too much leeway, sometimes faculty will just rest on the residents or on the senior students to assess the junior students. So that's fine. That's a very important part of assessment. We need to keep it under control. So also the experienced clinical faculty.
Yeah, I think we lost Cesar, thankfully, the last few minutes. Can we have you turn on your video so that we would like to have a picture of you with all of you? Cesar, we lost you in between. So we said we will all turn on the videos and get a picture. So please be with us for the next 3 minutes. Yes. Yes, smile. Yes, this is the second set. Here we go. Because we have many participants, like I'm taking it in batches. Yes. And then here we go. Yes. Thank you, Cesar. Thank you so much. And actually, it was like watching a movie live, like how assessment is happening and what is it that we can actually, like we got a lot of inputs on how exactly, because this was burning issue, like all of us have this. Like, how do we do it? And there are certain key things that you said as to like your tracing and your zone of professional, that learning edge that you talked about. and active observation and feedback, especially I think the feedback component, and, how exactly we can get this in a positive way. Like, yeah, how can I actually motivate my faculty to do it? So it was really, really truly inspiring. And thank you so much, Cesar. And we would seek your assistance whenever we sort of delve much deeper into this. And when you talk about analytics, like I was really happy with, like, yes, I think that really has a way to go in our institutions. Thank you so much. And I express my sincere thanks on behalf of the delegates too. So thank you once again.
Thank you.
Cesar.
Good evening over there. Bye.
Yeah, thanks. And I'm sure you're amidst your work and you spared time and you're going back to work and we're going back to sleep.
Yes.
Yeah, thank
As
you
soon
so
as
much.
possible. Bye.
Thank you, Cesar. Bye-bye. Bye.
Congrats, Vinuta. Nice to see you.
Thank you, Elsa. Where are you?
Yeah, I'm at home.
Hi.
I'm attending a session. Nice.
Thank you so much. Thank you so much. And thank you for your inputs.
Yeah.
Thank